Welcome to the second day of World Hemophilia Week. Today, we are going to focus on the future of technology and access to healthcare. And with us are Brian O'Mahony, CEO of the Irish Hemophilia Society, Kate Kerr, Director of Research at MNet, and Wanda van Hirta, Chief Scientific Officer at Enzire and Management Team Member of the HTC at Nijmegen, Eindhoven, and Maastricht. We have several topics to discuss, and we'll start with home delivery and telemedicine. With the advent of COVID-19, these areas were hugely implemented to minimize patients traveling to the centers and the risks of becoming infected. So my first question to open the debate to all three, it's do you think this trend will continue after the pandemic stops, or at least be controlled? And we can start with Kate.
Thank you. So home delivery of all the clotting factors and any other medical supplies that you need to administer treatment to yourself or to your child have been available for patients in the UK with severe bleeding disorders or those who are on regular treatment for as long as I can remember. So actually this is not new for the UK, and I'm sure that Brian will say it's not new for Ireland either. I think we just need to remember that there are all of those patients who don't have severe bleeding disorders and who aren't on home treatment regularly, to make sure that they don't get left behind and to make sure that they've always got access to treatment wherever they are. And whether that goes through a home delivery service or the product is delivered from the haemophilia centre to the patient at home will depend on where you are. But I think across Europe, we need, now that we've got this as an option for patients, I think everybody likes it, and I think we should try really hard to keep it, because actually it's in the patient's best interests.
Thank you. Wanda?
Yeah, honestly, I also hope that it will stay. In the Netherlands, it's also partly related, similar to what Kate was saying, that for the severe patients, some they have home delivery and some don't have it. But we are in a very small country, which makes it less difficult compared to the others, because for us, a hemophilia treatment center is maximally 50 kilometers away. So that makes it far more easier. Nevertheless, I sincerely hope that we can organize that far better for not only for patients in Western world countries, but also a little bit beyond that in other parts of Europe.
Yeah. Brian, your views on that, and I can make the bridge for the second question, is regarding home delivery. What can patient organizations do to ensure that this will continue?
Well, in my view, home delivery should be an automatic part of comprehensive haemophilia care. It has been in Ireland as well for many years. I mean, effectively, your treatment centre of first resort is the refrigerator or press in your house. So the factor should be delivered to your home. I think it's so obvious, I'm not even sure we need to discuss this. I think it minimizes your attendance at hospitals. It actually, if the factor is scanned into your home, it increases the tracking and tracing capability. It's confidential, and also typically most services would have a procedure for emergency delivery. I think for countries, and I know there are some well-resourced countries who have only just introduced this during the pandemic, how do they continue this? I think they need to be sure that they evaluate the outcome of the change this has made. They need to be talking to people with haemophilia and saying, look, what difference has this made to your quality of life, to your quality of care during the pandemic, having home delivery? Do you want this to continue? What advantages has this conferred on you? And collect that experiential data if they want it to continue. Because what you don't want is a reversal to the old normal at the end of a pandemic.
Yeah, and what can the patient organization do to collaborate and to reinforce this state of affairs?
Well, I think come up with the qualitative questions that you would ask and collect the data, send a survey out to people.
Yeah, that's great. That's right. Telemedicine is another issue that has been on the table right now. And how do you think this has been working for both patients and clinicians? Wanda, we can start with you.
Yeah, thank you for that interesting question. I think, you may know that I'm very much interested in that specific part because I believe in what we call personalized medicine or personalized or precision medicine, what's in the name. But if you want to do that, I think it's very important that you also give them the tools to perform that properly. And what I mean by that is I fully agree that it is a very good system to go to telemedicine, but the advantage should be that the patient even do not have to go to the hospital for, let's say, some diagnostic purposes. If you can also do that at home, and that's where we are going for, if you can do that at home, which we call personalized diagnostics, then you have the whole cascade of doing telemedicine or personalized medicine. So you need additional tools to that. If you don't have these tools, like we have had in Nijmegen, we have had the Health Bridge initiative. So patients had telemedicine, but when they wanted to do some additional analysis, they still had to come to the hospital. So we wanted to create a system in which the patient can perform also personalized diagnostics if they need it. I'm not saying that they constantly have to do that, but if they have that proposition, they can use that to have the proper discussion with their treatment, for their treatment with the physician. Sorry.
So the patients are very important to this trend continues. Yeah, it's obviously. And Kate, what should change if this trend is for this trend be maintained in terms of organization and management?
So I think we need to be really careful. I love the whole process of having moved within a year from not being able to do any kind of telemedicine because of rules in health authorities to being able to do everything virtually. But we just need to be careful that for the recipients of our telemedicine calls, that they are prepared for them. So I've certainly heard young men saying that normally they don't think about their haemophilia very much. They think about it on the train journey up to the hospital. And so if they're not doing that train journey anymore, we need to make sure that they're thinking about the kinds of things they might want to discuss in that possibly quite short teleconsultation that they have. And then my other concern is, and it is a little concern, and I think it's very easily overcome, is we have what I call the door handle conversation. So you've done your whole consultation, everybody's about to leave the room, and as the patient's got their hand on the door handle, they say, oh, by the way. And it is the mum to tell you that she's pregnant and she's having another baby boy, or something comes out that hasn't come out in the consultation before. And if we are very quick as healthcare providers at hanging up, be it on the phone or on Zoom, we lose that opportunity for that last little minute of what it is that the patient really wants to discuss. So I think we have to change the way we do our consultations to make them much more patient-led. And that means we need to have much more engagement with the patient organisations about how they encourage patients to participate in their consultations.
Great. Yeah, it's true. Patients need to be more vocative towards the health professionals. And Brian, and are patients losing by not meeting face-to-face with clinicians? This could lead to a sense of losing the touch, the personal touch that they are used to?
I don't think so. And I want to comment first on what Kate said. I really agree with that point. I love the concept of a door handle conversation. And in fact, preparation for the virtual consultation is really important. We're rolling out a patient portal at the moment where you can push and pull information. So it's really important that's an element of it. Are you missing out by not meeting the person? Yes, I think there's certainly an element of that. There are some. You don't get 100% of the value from a telemedicine consultation. I think you get 70 to 80% of the value. There are also some individuals for whom it will not work. And I think you have to have that choice scenario there. There are some individuals who say, no, I want to speak to the nurse or the doctor in person. I don't want to do this over the phone. Now, we've given people the choice of a phone call or a video consultation. I have to say that the pandemic has really driven change here. So now telemedicine is an idea whose time has arrived. And I think all of the barriers that people had, all of the excuses that they for not doing this in the past have vaporized. And I think this is now a strong part of the service. We did a survey with our healthcare workers, which was published in Haemophilia, showing that 79% of the healthcare workers want to continue with telemedicine in the future. In terms of patients, 79% felt that this improved their access to care. 82% believe that it decreased the inconvenience of traveling to the centre. 94% said it was easy to use, and 97% said it facilitated good communication. So I think if you give people the choice of a video or telephone consultation. And once this is set up correctly and a bit of preparation done, I think you're getting the majority of the value of the in-person consultation can be done with telemedicine. Obviously, apart from the potential, the outlier being bloods, phlebotomy. So you really can't do phlebotomy over a consultation, which is I really like Vander's point about near patient testing, which I think is a different and a deeper conversation, would certainly be worth a separate podcast.
Yeah. Vanda?
Thank you, Brian, to take that floor, because I also believe that the near patient testing might be an option, but addition to this telemedicine approach, remember that personalized diagnostics offers you also additional tools for telemedicine, because, for example, if a patient measures multiple times, for example, his factor VIII level at home, and that as a physician you get that message that he's measuring 3-4 times a week for something like that, then that might also be an attention point for the physician to contact directly the patient by themselves, if the patient is willing to get that access to the physician. Because remember, nowadays patients are coming to our hospital, if they are a severe patient, maximally 2 times a year. That's it, and they even don't know how many bleeds they had, for example.
Yeah. Yep. And what does it take to extend this model to an European level? Because there are a lot of disparities between a huge number of European countries, and of course we all agree that this could be the future, and is to maximize the management of hemophilia. What do you think? What does it take to make it happen in all the countries, or at least at certain level?
Miguel, I think it's even narrower than that, in the sense that sometimes you even have to work hard to roll it out at the national level. We've rolled it out really successfully in the adult center. There was a problem with the pediatric center because of the technology in the hospital, and they're a bit behind the curve in terms of that. So you have to have technology, you have to have the good Wi-Fi connection, you have to have the people who are willing to engage with this. We've also found a small cohort of older members who are uncomfortable with technology. We're actually, through the society, starting to provide them with technology grants. I think, unlike the USA, where one of the biggest barriers to rolling this out in the USA is billing, is how do you charge people for this? They're obsessed with that. That wouldn't be the same. That wouldn't achieve the same level of priority in Europe in terms of how do you charge for it. I think it's really looking at what setting out guidelines and a consensus on what you can easily do virtually, extra add-ons you can do virtually, looking at the items that it's very, very difficult to do virtually, and then reaching some consensus on this, and then looking at the training required, look at the education required for the patient population, look at the technology required.
Yeah. Kate, do you want to add something to this? To the extension, what we do need at an European level to maximize and make some uniformity in the treatment of hemophilia and care?
So I think we need to think broadly and think innovatively. So, as we said earlier, a year ago, we wouldn't have thought we'd be able to do anything using technology like Zoom to see our patients. And yet here we are a year later, it's completely normal now. So we need to still think about what is right for the patients. So it should actually be patients and patient organisations very involved in this, helping shape the way forward, not just having things imposed on them by healthcare providers.
Mm-hmm. Great. So let's move to the other topic with the technologies, the new technologies that we have right now, or we are about to have, like new replacement therapies and gene therapies for hemophilia, evolving at warp speed, as we know. Hub and spoke models and registries are being considered paramount in the management of hemophilia. So there are a lot of challenges when we compare with the current situation right now. So starting with the hub and spoke models, Brian, can you briefly explain to the audience what are we talking about when we talk about hub and spoke models for bleeding disorders?
Well, I think you're really talking about a center where they provide the full comprehensive range of services, being a hub, and a spoke then being a center providing a more limited and but still clearly defined set of services. Now there is already to an extent a hub and spoke model in Europe for years, where we're looking at the certification of hemophilia treatment centers into comprehensive care centers, EHCCCs, or treatment centers, EHTCs. You already have to an extent a hub and spoke model. So there's already a process for that. Now I think a couple of years ago, with the start of licensing of the novel therapies, EHC and EHAD set out a joint statement looking at how novel therapies should be introduced in the community, and then there was an agreement that novel therapies uh, should be prescribed and monitored through expert centers, so primarily through comprehensive care centers. That was already the start of that process. Now, if you then take that a step further and go to gene therapy, which is going to be an irreversible one-off therapy, which requires full and multi-stage informed consent, and where I can guarantee you that the payers won't want every hospital in the country being able to dispense this because of the cost ramifications. I think that's a clear example of the need for a further explanation on this hub and spoke model, where I think you will see with gene therapy, you'll see dosing or supervising centers at one level, a small number in each country, and then they'd be the hub, and then the spokes would be the other centers who would feed patients into them, who would liaise with them, who would monitor how that works, and there would be an agreed division of labor in something as complex as gene therapy between the main work and also the routine ongoing monitoring of bloods, where this may be able to be done through a spoke center.
It's clearly an improvement. How do you think this differ from the actual situation of hemophilia treatment and comprehensive centers? Wanda?
Yeah. Listen, in the Netherlands, once more, again, we are a very small country and we have several comprehensive care centers. And what you already see that even that, for example, our center, which is in Nijmegen, Eindhoven, Maastricht, are joining together. So they are in a very close situation next to each other. So we don't have it, but nevertheless, I have seen many centers in the United States, for example, where they do work with hub and spoke centers. So they have that facility over there, and they do. What I know from those centers, they are using telemedicine to have the discussions with those spoke centers. So I think that is very intriguing, because for patients this is a huge beneficial system. What they actually do is they send over nurses and sometimes even physicians to the spoke centers from that comprehensive care center to help the physicians in the spoke centers how to treat the patients, etc. So I think it's a very elegant way, and especially if you have a good telemedicine combination with the hub, between the hub and the spoke center, that helps tremendously, to my opinion.
Thank you. Kate, do you want to add something about this progressive way of management of hemophilia?
So I think I agree with everything that's already been said. In pediatrics, which is where I've always worked, we've always had, not just within haemophilia, but for specialist pediatrics, there's always been a hub and spoke model where care is delivered at the spoke, which is usually closer to where the patient and family live, and is therefore more convenient, but is still managed by the people in the hub. And I think that model works really well, but it only works really well if the patient and family are in control of some of their information. They know what's happening, they know what should be happening next, and they are very much part of the team. And they're a very important part of the team. And if they're not, then the potential is that they get lost and things go wrong. So actually, again, it comes back to empowering patients through the organizations, the patient organizations nationally.
So you see that as a risk to this model, right?
I think it can be if you don't have everybody in the model really engaged. If the expectation from me as the healthcare provider is that you will come back in a year and then you don't, and I forget about you, then there is a risk.
Yeah, right. And let's move to registries. We all agree that it's one of the burning issues about management of hemophilia in the world and Europe, and depends of the country, of course. But why is so difficult to implement it? Brian, we can start it with you.
Well, this is often a surreal debate, because if I have a blood test done in the center, then the question could be asked, who owns that data? And this surreal stuff goes on. And I think, to me, one of the fundamental difficulties in implementing registries and in implementing collaboration between registries is ownership. Who owns the data? Who controls the data? Who gets to publish the data? There's a certain amount of jockeying for position there, which is never helpful. And I go back to an EMA meeting on inhibitors in 2006, where the clear recommendation was that lots of the registries should get together and pool their data to see what the real risk of inhibitors was. And everybody agreed, and everybody wanted to control the registry that came out of it. So that's the big problem. I think registries are an obvious way of they're really beneficial. First of all, they give visibility to the condition. They allow you to predict demand and supply. And also, I think increasingly, especially with the requirement no longer to have clinical trials for pediatric drugs in hemophilia, they will take the place of post-marketing surveillance data collection. So I think registries are vitally important, and especially with complex one-off therapies like gene therapy. If you don't have a registry, a global registry, you're going to miss rare events.
Yeah. Vander, registries for life. We should control it.
Yeah, I think it's important to have registries. I don't have to recall what Brian was saying, but what I wanted to add to that is the problem with registries, at least what I do see in the Netherlands, is that it is just one direction. It goes, the patient have to fill in the forms, but there is no feedback or there is no benefit for the patient. And I think we have to find a solution for that. If the patient have some beneficials related to that registry, they are more committed to give that information. And that's what I do miss in all the registries so far. There is not a real commitment for the patient.
Yeah, so lots of work to do about that. So people must be empowered about the registries. Kate, do you think it's important? What should be the role of the health professionals and the patient organizations towards this?
So I think we should be working together to think about which data we're collecting and to whom that data is important or relevant. So as Brian said, we get patients to fill in lots of things, and actually if we then never tell them the results of their quality of life survey, why would they want to do it every single time they come? But I also think we need to be smarter about how we record patients and their known or potential diagnosis. So there's the EHC and EAHAD are working quite hard at the moment on women with bleeding disorders and how they are really underrepresented on patient registries. And that's because we don't record them as carriers of haemophilia or potential carriers of haemophilia or women with haemophilia or whatever we want to call them. So then they're unseen, and actually the great value of having national and international registries is, as Brian said, to make these people visible.
So Brian, what data should the registry capture?
It depends on the registry. I mean, obviously, I think, look, if you want collaboration internationally, you define a core data set and you collect that at least, and then more if you can. But at least if everybody collaborates on a core data set and everybody collects those core pieces, then you can actually compare data from one country with another. It's where you all collect different things and you have different definitions and different definition of a previously treated or minimally treated, or what's a high titer or low titer inhibitor. It gets crazy. It gets very, very hard retrospectively to add those registries together. So I think with something like gene therapy and novel therapies, the idea is before they're licensed, there should be agreement on what are the core outcomes you need to look at, what's the core data you need to collect. With gene therapy, I think, as you know, WFH are doing a gene therapy registry, a global one. They've already established the areas where they want this core data set: demographics, medical and clinical history, infusion details, safety data, efficacy data, and patient-reported outcome measures and mortality. So there's a number of clear headings, and obviously there's no restriction on people collecting more than that, but there should be an agreed core data set that everybody collects.
So we are reaching our limit of time. I invite you to a final remark about these important issues that we talked about today: the innovation and access to healthcare, registries. So last words, we can start with Care.
So I think the really important thing for all of this going forward is that we engage with patients and patient organisations, because otherwise if the patients are not engaged, they're not going to complete any of the data in the registries. We won't have the registries and we won't have all of the innovation that comes from something as simple as being on a register.
Thank you. Wanda?
I think you have to put the patient more central in respect to all kinds of activities. When it goes about telemedicine, when it goes about registries, think about the patient benefit. If you find that, I think it's getting much more easy. And you also have to convince doctors, but believe me, it may cost them a lot of time to fill all those questionnaires, etc. So if you can find a rationale between the patient and the physician, that I think that is the way to go forward.
Thank you. Brian?
I think all of these topics are linked. If you look at registries, I think it's much easier to get registries if you have a hub and spoke model. The hubs are more inclined to collect and submit that data. And in a world where people are going to be going on novel therapies and gene therapy and won't want to be visiting the centers that often, one of the best ways of collecting that data is through telemedicine. So I think all of these are linked.
And I think also there we should be moving forwards to having all of the quality of life assessments being able to be done electronically, so it's not a poor patient sitting with a pencil and ticking boxes for some poor nurse or data manager to transcribe into something else. It just happens automatically.
Yeah, and ultimately the shared decision-making process will be for sure much better. And with this, we conclude our talk. Thanks a lot to our speakers for your very useful insights about these important matters. And thank you for watching us in the second day of World Hemophilia Week. Stay tuned for tomorrow and keep safe.